Hello, and welcome to this mini panel on breast cancer, where I'll be joined by several colleagues who I'll introduce in a moment. My name is Bill Gradisher, professor of medicine at Northwestern University. I'm a breast oncologist there, and I'm joined by several other well-known colleagues, and we'll go around very quickly and have them introduce themselves personally. And we'll start with Sarah Hurvitz.
Sarah Hurvitz, professor of medicine, breast oncologist at University of California, Los Angeles, Johnson Comprehensive Cancer Center. It's nice to be here with you this Saturday.
Norman Womark. I'm professor of surgery at the University of Pittsburgh and chairman of the NSABP and the contact principal investigator of the NRG Oncology Cooperative Group.
My name is Rennie Butler. I'm associate professor in breast imaging in the Department of Radiology at Yale School of Medicine and Yale New Haven Hospital, and it's a pleasure to be here with you all.
Tom Buchholz. I'm a professor emeritus of radiation oncology at the University of Texas MD Anderson Cancer Center and the medical director of Scripps MD Anderson Cancer Center in San Diego.
So this is a 63-year-old female diagnosed in 2018 with a stage 2 breast cancer, T2N0M0 left breast. It was an invasive ductal carcinoma that was ER and HER2 positive. She underwent neoadjuvant therapy, followed by a lumpectomy, adjuvant radiation therapy, then trastuzumab, pertuzumab, followed by an anastrozole. So she completed all of that, but in 2020, she developed left shoulder pain and was found to have a T3 met in the spinal canal. And she underwent radiation therapy, additional chemotherapy with significant toxicity. I don't think we were ever told, unless it's subsequently clarified, what that chemotherapy was, and then developed progression on that chemotherapy. So now she started on TDM1, and the questions are, should she continue that or consider other treatment options, et cetera? We'll come to that in a moment. So let's go through it in a bit more detail. As you heard, she presented with pain, weakness, some fatigue. Her performance status was a little bit compromised because of those symptoms. She had a prior history of a basal cell near her right eye. She does have some other associated problems, including anxiety and panic attacks, osteoporosis. She's postmenopausal now. She's had a hysterectomy. There's no history of breastfeeding, oral contraceptives, hormonal replacement therapy. She was a smoker in the past, but no drug or alcohol use. And there's no family history of breast cancer, but her father did have a diagnosis of non-Hodgkin's lymphoma. So in more detail, this is the time sequence. She noted the initial diagnosis back in 2018. It was a mixed tumor with both ductal and lobular features. She ultimately underwent neoadjuvant chemotherapy with HER2-directed therapy, docetaxel, carbo, and then trastuzumab, pertuzumab combined. She underwent a lumpectomy and was found to have a T2N0 lesion, ER positive. PR was low, and she ended up being FISH positive. So she completed radiation therapy. Her cardiac function remained good. She had some imaging done of the spine. There were no acute issues, some osteopenia. And again, there was nothing going on at that time point. So just a quick look back in time, Dr. Butler.
Here we have a single image from a sagittal plane from a contrast-enhanced subtracted MRI. This would be very analogous to an MLO mammography image. And this, of course, would be done in order to evaluate the extent of disease in a patient with a newly diagnosed breast cancer. In this case, there's very minimal surrounding background parenchymal enhancement, which makes the negative predictive value of this exam very high. And this just confirms the known mass here, but without any evidence of additional disease in the ipsilateral breast, and the contralateral breast was also reportedly negative.
Okay, so let's go on with the rest of her history quickly. So through 2019, she's had a variety of imaging studies done. Presumably she was having some complaints, but there was no clear evidence of metastatic disease anywhere in 2019. Her cardiac function continued to be good. Subsequent mammograms were all right as well. She underwent repeat CT scan in May of 2019. It was fine. A follow-up mammogram looked okay. And then we get to October of 2020, where again, there were complaints that prompted a series of imaging studies. The brain looked okay. However, in the T-spine, there was a metastases seen, and there was some concern for compression of the cord. PET CT was done that confirmed the same thing. She had Garden 360 done, which did demonstrate some mutations present, specifically an ESR mutation, CDK4 amplification, and FGFR1 amplification, and then some others as well. She underwent radiation therapy to that T3 lesion and was started on paclitaxel, trastuzumab, and pertuzumab. So the Cleopatra-like regimen, but in this case with paclitaxel, but she was developing significant toxicity, including edema, and it wasn't getting better. So that was problematic. And then in January, she gets tumor markers that show that she had an elevated CA2729. And further imaging in February of 2021, so very recently, shows worsening of the T3 compression fracture, as well as a new compression fracture at both T5 and T12. And again, she, at that point, based on these findings, is started on TDM1 and a bone-modifying agent, zoledronic acid. So in summary, just to go back, she had an early-stage breast cancer. She received neoadjuvant therapy, completed her postoperative HER2-directed therapy along with endocrine therapy, then developed progression of disease manifested by disease in the bone, got at that point a treatment with taxane, an alternative taxane, trastuzumab, pertuzumab, and then has now progression of disease on TDM1. So the first question is, based on these findings, which are largely restricted to bone and no visceral disease that's apparent at this point, should she continue on TDM1, or in light of all the other newer therapies that have been introduced in the last year, is there something that you would use in preference to that at this point? So I would direct this one to start things out to Sarah.
So in cases like this, I always want to make sure I know what I'm treating. So I always question, is this truly a HER2 positive breast cancer? I noted that at least one of them was 2+ by IHC and FISH positive, but I didn't see the ratio or the copy number. And there are cases where there's aneuploidy or ploidy, and it's really not a HER2-driven tumor. And the reason I bring this up is I noticed in the Garden 360, although she had FGF receptor amplification, I didn't see a HER2 amplification. Right. So before starting on HER2-targeted therapy, I would really, in this type of situation, query the pathology. I think pathology is critical here as we embark on treatment decision-making for this patient. Assuming it is HER2 positive, I would also note that she only got a couple of months of mileage out of frontline Cleopatra-based THP regimen. Now, she did have HP and taxane, but with a nice 18-month or so interval before being diagnosed with metastatic disease, but that's not the typical type of mileage that we get out. The other thing I would make sure she's truly progressing, and meet with my radiologist and go over the images in detail and say, are there truly new bone lesions, or are we just seeing collapse of old areas that were already involved? It's really hard to follow bone lesions. Assuming it is progression, assuming it is HER2 positive, I think TDM1 is a perfectly appropriate therapy to go on in the second-line setting. It's gold standard.
So again, this patient is strongly ER positive, or was. So in addition to the HER2-directed therapy, which you said you would continue, is there anything you would do to optimize her endocrine therapy? Because the pattern we're seeing in this particular case is sort of the distribution that's more common with endocrine driven cancer, or I'm sorry, ER positive driven cancer.
Yeah, absolutely. I mean, I noted she had an ESR1 mutation, so she had been treated with anastrozole and perhaps acquired that throughout her therapy. And so I would lean toward using a fulvestrant-based approach. I'm not one that typically combines that with TDM1. I would rather sequence these strategies, use TDM1 as a single agent, and as a different line of therapy. I think it would be fine to consider fulvestrant trastuzumab or fulvestrant trastuzumab pertuzumab or lapatinib, and we have data to support all of these types of regimens. But again, as you pointed out, these are bone metastases. She has an ESR1 mutation. There's no HER2 mutate or amplification noted in the NGS. So should we really just be using fulvestrant and a CDK4/6 inhibitor? And is this patient, type of patient benefiting from HER2 directed therapy?
Right. So, Tom, we talked earlier in a different scenario about oligometastatic disease, and now this patient at this point presumably has another couple areas that are suspicious in the spine. But could you comment, how do you palliate something that is isolated in the spine, and then also the more current scenario where there's a few more spots? What are the considerations for radiation therapy, as well as, sparing the cord? Can you comment on those things?
Sure. Historically, radiation in the setting of metastatic disease was used to just improve pain and symptoms and protect, in the case of spinal cord compression, protect against further neurologic injury from the disease. So as if I were to approach this case back at the time of her recurrence, I would want to evaluate this with a neurosurgical colleague, because the combination of surgical resection in the setting of an acute spinal cord compression combined with radiation yields long-term better outcome than just radiation alone. So sometimes these are resectable, sometimes they're not. It's more than just doing a laminectomy. You could even do a vertebral body resection and full decompression. The next approach is when you're confronted with a treatment of a bony metastasis, you have to say, are we going to treat this more aggressively and maybe use what's called the stereotactic body radiation approach, where we could carefully conform the radiation dose around the metastases within the vertebral body and spare dose to the underlying spinal cord, which is the dose limiting toxicity. That's very commonly done. And if you're going to treat in a more definitive or ablative type of setting, like that of oligometastases, you might take that on, as opposed to someone with widespread metastatic disease where the goal is just to provide short-term pain relief. Then I think simple techniques and shorter treatment courses are very appropriate. You could even give a single fraction these days and yield excellent outcome. So back to Sarah's point, I think working with imaging and other people involved to really understand the extent of her metastatic disease. What are true metastases? Is this truly progressive? How many sites of disease does she currently have? The use of radiation in the setting of this oligometastases, which are usually defined as 5 or fewer metastases, is still somewhat of a research question. We're awaiting randomized prospective trials about using this even on asymptomatic disease sites as a method of improving progression disease-free survival. There's some encouraging data that it may, but it's still an open research question currently. So again, defining the goal of treatment and adjusting your dose and technique accordingly.
Great. Norm, I didn't call on you for anything. You have anything to throw in here?
Yeah, I certainly agree with Sarah's emphasis on making certain that the tumor that you're treating is as well characterized as possible. And I was confused as to on what the Guardant assay was performed. Is it really a HER2 positive lesion? And one question I am curious. I mean, assuming that this was unequivocal progression, on TDM1, and we discussed CDK4/6 inhibitor, which I think is a very reasonable and probably preferable approach. At what point would you consider tucatinib, assuming that perhaps we're dealing with a P95 truncated moiety of HER2, and you'd rather go with a tyrosine kinase inhibitor?
Yeah, we have the availability of tucatinib, capecitabine, trastuzumab in the second line setting. The FDA approved it here, so we are able to use it in patients like this. The HER2 CLIMB study didn't evaluate the use of tucatinib in the second line setting, but I think the approval was based on its therapeutic index, which was quite favorable, as well as its activity in the brain in patients with active or stable brain metastases. So I think it would be a perfectly appropriate choice, especially given how poorly she tolerated the paclitaxel-based therapy. And yes, assuming this is HER2 driven, her progression-free survival on frontline standard of care THP was horrible. So maybe a different type of drug would be preferred here and would be better, more effective.
All right, let's go on to the next scenario. So this is a 49-year-old woman with newly diagnosed stage 4 disease, a T4N3M1 lesion, ER positive, PR negative, HER2 positive, invasive ductal carcinoma of the left breast. She has metastatic disease in the sternum and was found to have a concurrent stage 3 ovarian cancer. In addition to what we already heard about this 49-year-old woman, think about a different scenario where she has concurrent ovarian cancer, stage 3. So she has a known breast cancer. It is ER positive. It is HER2 positive. We talked about how to optimally treat her with HER2-directed therapy and endocrine therapy. But if we throw into the mix that this patient also has a concurrent stage 3 ovarian cancer, how would that alter the sequence of therapy and the optimal therapy?
So, first of all, I would say, I think it's important. I've had several patients diagnosed with concurrent ovarian cancer with metastatic breast cancer. And when we've looked at the tumors side by side and measured ER and PR and HER2, several of them we've found are actually breast cancer metastases to the ovaries, which is less of a complicated situation following the Occam's razor, right? If we can find the simplest reason for something, it's usually right. So I would make sure that we've ruled out that this is actually all breast cancer. Assuming she does have 2 concurrent cancers, I'd make sure we've done our BRCA mutation testing. And I think you treat with optimal surgical debulking. She's already had a taxane and didn't tolerate it, so maybe platinum. Now I'm stretching here. The cancer that she has, which is metastatic, is the one I think that's going to take primacy in terms of treating systemically. But I think locally and regionally, you should treat the ovarian cancer as you would with curative intent.
So I guess the question relative to platinum is answered. What about a PARP inhibitor?
Yeah, absolutely. It's indicated outside of just BRCA mutated in ovarian. So, but it would be good to know the BRCA status as well, just from the breast cancer perspective. Interestingly, we don't really have data supporting the use of PARP inhibitors in HER2 positive breast cancer because the companies developing PARP inhibitors, excluded HER2 positive breast cancer as such a crowded field, but it should work in HER2 positive BRCA associated breast cancers.
Yeah, and just as a minor point too, I mean, there is often the perception that the BRCA mutations are going to be present, specifically in triple negative breast cancer, which is clearly not the case. And, of course, if you look at the fraction of patients with ER positive disease that have a BRCA mutation, it's low, but the number of ER positive patients is high. So again, it would be worth knowing that for a variety of reasons, because it may open up another therapeutic strategy for both the breast cancer as well as the ovarian cancer.